So now the topic of discussion that we are going to talk about is otitis media with effusion. Now talking about its classification within otitis media, it falls under the topic of non-suppurative otitis media, and in non-suppurative otitis media we talk about otitis media with effusion and adhesive otitis media. So here we're talking about what? Otitis media with effusion, right? Now this is several time asked question. It is asked several times in university exams, right? And talking about the dates where it is asked, it is asked in 2023, it is asked in 2021, several 2015, 2002. Now before getting in detail about otitis media with effusion, let's talk about its introduction. Now talking about its introduction, what are the other name by which the otitis media with effusion is known? The other name through which the otitis media with effusion is known is through what? Secretory otitis media, mucoid otitis media, gluer, right? Serous otitis media. These are the different names, or we can say chronic secretory otitis media also, right? So these are chronic secretory otitis media, serous otitis media, right? Mucoid otitis media, gluer, or also we can say catarrhal otitis media. Now okay, now here what will happen is that there is presence of medullary fluid within without the acute sign of infection, right? There is presence of medullary fluid without the acute sign of infection, right? And it is what? It is extending up to what? Our mastoid ear cells also. Now it is what? It is followed by, or it is secondary to severe upper respiratory tract infection, right? And also you can say acute otitis media, right? Now the fluid that is found inside the middle ear is of what? Non-purulent, thick and viscous with sterile type, right? And it is mainly commonly seen in school-going children, right? School-going children. Now as you can say, now what we can bring into the conclusion is that, right, there is presence of what? Mucoid effusion, right? Within middle ear cleft, right? Within middle ear cleft, that includes what? That includes our middle ear, eustachian tube, Otitis, antrum, and mastoid ear cells, right? Now there is what? There is serous mucoid effusion in middle ear cleft in this structure, right? With no with no frank pus, right? With no frank pus, and which is sterile, thick and viscous in nature, right? So it is mainly commonly present in school-going children. Now talking about its pathogenesis, right? There are two mechanisms of what? Two mechanisms. The first one is because of first malfunctioning of eustachian tube, right? Now here the eustachian tube, the eustachian tube fails, right? It fails to aerate middle ear and is unable to drain the fluid, right, of middle ear. The one is the malfunctioning of eustachian tube, and another is because of increased secretory activities of middle ear mucosa, right? Now here at this time what will happen is that there will be what? There will be increase in, right, middle ear mucosa, right? The number of mucus or secreting cell will be increased in what? Our this middle ear. So these are two mechanisms. One is malfunctioning of eustachian tube, and another is when there will be what? There will be increase in secretory activities of middle ear, right? Now talking about its etiology, right? Talking about its etiology, right? The mainly the etiology they are, right? The etiology includes what? It includes several. The first one is malfunctioning of what? Malfunctioning of eustachian tube. We have already mentioned about the malfunctioning of eustachian tube, right? We already talked in pathogenesis that because of what? Because of what? Because of malfunctioning of eustachian tube. And another is, what is our another? The another is our what? Because of allergies, right? Because of allergies. And another is our unresolved, right, otitis media. Similarly the other is our viral infection. Similarly the next one is what? The next one is increased in secretory activities of middle ear mucosa. I already mentioned about these things. Now talking about malfunctioning of eustachian tube, right? The malfunctioning of eustachian tube, it can be because of what? Because of various conditions, like it can be because of eustachian tube obstruction, right? It can be what? It can be because of what? Patulous eustachian tube, right? There can be patulous eustachian tube, but there will be what? Malfunctioning of eustachian tube. Similarly what? There will be palatal abnormalities, right? Abnormality of what? Our cleft palate or palate palsy, Similarly, what there can be because of what because of mucociliary pathology. So talking about the malfunction, the etiology, and talking under the topic of malfunction of eustachian tube, we already mentioned what there can be what eustachian tube obstruction. And eustachian obstruction, it can be because of various conditions, like it can be because of intrinsic factor or extrinsic factor, right? Talking about intrinsic factor and extrinsic factor, intrinsic factor, it can be because of what, it can be because of edema, infections, right? It can be because of allergic trauma, right? And talking about extrinsic factor, it can be because of adenoids, right? It can be because of adenoids, nasopharyngeal tumors, right? Nasopharyngeal tumors, right? And talking about patulous eustachian tube, right? Eustachian tube is patulous, but also there is what, there is malfunction of eustachian tube because of what, because of our reflux of secretions, right? Reflux of secretion. Similarly, palatal abnormality, I've already mentioned about what, cleft palate, palatal palsy, right? And talking about mucociliary, what mucociliary pathology, there can be what, there can be infection, allergy, smoke, various syndrome like Carter-Jenner syndrome, which includes of what, situs inversus, right? Bronchiectasis, ciliary dyskinesia, right? Similarly, Young syndrome, that includes azoospermia, bronchiectasis, right? Rhinosinusitis. Okay, now talking about the malfunction of eustachian tube, we are clear about what, there are several factors, like one is because of eustachian tube obstruction, one is the patulous eustachian tube also will cause, right, palatal abnormality. Similarly, what we talked about, mucociliary pathology in eustachian tube obstruction. We talked about intrinsic and extrinsic factors, right? Intrinsic and extrinsic factor. Similarly, in in our this patulous eustachian tube, we talked about what, we talked about reflux of secretions. In palate abnormality, cleft palate, we talked about palate palsy. In mucociliary pathologies, we talked about what, we talked about different syndromes, right? We talked about smoking habits. So these are the thing that we talk about in malfunctioning of eustachian tube. And talking about allergies, right? Now there are seasonal or perennial allergies to inhalant of food or stuffs, right? And this will lead to both obstruction and increase in secretory activities of middle ear, right? So allergies, what they will do is they will cause exaggeration, right? Exaggeration due to inhaled foodstuffs or any of the things, right, or any of the allergens. And this will lead to what, obstruction. It can lead to obstruction also, as we talked about in eustachian tube obstruction. And also there can be what, increase in secretory activities of middle ear. So that is how the allergy will play role in causing otitis media with effusion, right? And talking about unresolved otitis media, right, here what will happen is that, right, inadequate antibiotic course, right, they will, what they will do is they will just inactivate the infection but do not resolve it completely, right? And because of this low grade infection, right, the low grade infection which is occurring there will stimulate for mucosa to secrete more fluid, right? So unresolved otitis media with effusion, right, unresolved otitis media, let's say, will what, they will just inactivate the infection but will not completely what, resolve it. So there are maximum chances that it will cause stimulation of production of more fluid. So unresolved otitis media is the cause. Talking about viral infections, right, adenovirus, and what we have is rhinovirus. Now these are responsible for upper respiratory tract infection, and they are, as we know, that upper respiratory tract infection are the predisposing factor for our otitis media with effusion. So these are responsible. And similarly, talking about what, increase in secretory activity of the middle ear mucosa, we already talked, increased number of mucosa and serous secreting cells result in more secretion, right? Okay, these are the etiology, right? These are the etiologies to keep in mind. We already mentioned about infection, unresolved otitis media, right? We talked about adeno and rhinoviruses. We talked about allergies, the obstruction, right? They will cause increase in secretory activities, right? They can be barotrauma also can lead, right, particularly when traveling with upper respiratory tract infections, right? Similarly, we talked about eustachian tube obstruction also, right? There are several causes of eustachian tube obstruction. We mentioned about what, intrinsic and extrinsic factor. Talking about the intrinsic factor, we talked about what, we talked about infections, right, and allergies. Now, under these infections, what we can do is they can be chronic rhinitis, sinusitis, chronic tonsillitis, okay. And under this extrinsic factor, we talked about what? Nasopharynx tumor, right? We talked about what? We talked about adenine. Similarly, palate defect, we talked about these things also. Now, talking about the clinical feature, right? Talking about the clinical feature, how the patient is going to present to you. Initially, as I've already mentioned, the main age group that are affected are of about 5 to 8 years. Children are affected. Now, what they will do is there will be history presentation that the individual, the child has to sit in front bench, right? The child has to sit in front bench. At the back, he will not listen, right? He will not listen properly. Now, the parent will give the history of decrease in academic performances, right? Decrease in academic performances, right? And in home, the child has to turn on, right? He has to turn TV on in very loud noise, right? Very loud noise. Now, because of these things, what will happen is that in long run, the child is having problem in delayed and defective speech, right? The child is having problem, right? It is having delayed and defective speech. So these are the history, how the child is going to present to you, right? The age of the child is 5 to 8 years old. The child has to sit in front bench. Child is slowly decreasing in academic performances, right? And has to turn on TV in loud noise. And overall, after a long course of time, there will be delayed and defectiveness of speech, right? Speech. So this is how the child is presented to you, right? Now if such history is brought to you, then you have to do probable diagnosis of otitis media with effusion, right? Now this condition is usually bilateral, right? And if there will be unilateral condition, then the patient may not present with the above mentioned features just before what we told, right? Because there will be 1 year to function well, that's why. Now, talking about the symptom, as I've already said, right, there will be hearing loss. Now, this hearing loss will be what? This will be insidious and of mild to moderate degree, right? It will be insidious, mild to moderate degree, right? And the child will have what? The patient will have oral fullness, right? Pulsatile cracking, tinnitus can be heard, right? There will be balance disturbance, predisposing factor like smoking, childhood ear infection or nasal secretion can be there, right? Now, as already mentioned, child will present with what? He will present with hearing impairment, right? Child will present with hearing impairment, right? Now if the child are very young and they are not able to complain, then what they will do is they will frequently, right? They will frequently take hand to the ear, right? They will frequently take hand to their ear and they will rub them, right? They will rub ears. Now, parent need to pay attention about the activities of children also, right? Now, on long run, as I've already said, speech and language deformity will be found, right? And talking about otalgia, right, ear pain, right? Otalgia is not the symptom of OME, right, but recurrent otalgia, right? Recurrent otalgia is usually associated with OME, right? It is usually associated with OME. Now, these are how the patient will be presented to you. Now, talking about otoscopic finding, right? Now, talking about what signs, right? Above we talked about what symptom, history and symptom. Above we talked about history and symptom. Talking about signs, right? Otoscopic finding. Now, talking about otoscopic finding, as you can see, the tympanic membrane is dull and opaque, right? Dull, opaque. It is lusterless also, right? And there is loss of light reflex. As you can see, there is no light reflex, right? Now, along with it, what we can see is varying degree of retraction. It can be fully or slightly bulged, right? Talking about what? Retraction. It is fully or slightly bulged, and there is varying degree of retraction also. And in otoscopic finding, what we can see is the ear fluid levels. We can see ear fluid levels also, or bubbles can be seen in tympanic membrane, right? and the mobility of tympanic membrane is restricted. So talking about otoscopic finding, we are clear that in otoscopic finding, tympanic membrane is dull, right? It is lusterless, opaque, and there is loss of light reflex. And talking about the retraction, there is varying degree of retraction with fully or slightly bulged tympanic membrane. Similarly, the fluid level, right, or the air bubbles can be seen, and more motility of tympanic membrane is what it is restricted. So these are the otoscopic finding. And talking about now further, talking about test, right? We talk now the okay. We talked about what otoscopic finding. Now talking about what our tuning fork, right? Tuning fork test, right? Tuning fork test. Now talking about tuning fork test, Weber's, what will Weber will do is Weber's, it will lateralize to affected ear, right? Affected ear. That means it is what it is showing what conductive hearing loss, right? And Rennie's, right? Rennie's, it is negative on affected ear, right? Affected ear. Weber is lateralizing toward affected ear. That means what it is conducting hearing loss, right? Now Rennie's, it is negative on affected ear. Now okay, yes, tuning fork test, we found out that it is conducting hearing loss, right? And talking about PTA, right, pure tone audiometry, what will happen is that there will be conducting hearing loss of about 20 to 40 decibel unless there will be ossicular discontinuity, right? If ossicular discontinuity will be found, then at the time what we do is there will be about greater than 40 decibel of hearing loss, right? Now as it is mentioning that sometimes sensorineural hearing loss will be also there due to fluid pressing on round window membrane, right? Okay, now these are this what investigations we can see. Now talking about the management, now in management we need to talk about investigation and treatment portion. And in investigation portion, right, if the child is very, if he is very young, less than 5 years, right, less than 5 years, child is less than 5 years, then what we can do is we can do PTA, right? The patient won't cooperate, so what we do is we do play audiometry, right, or free field audiometry. And if the child is greater than 5 years, at the time what we can do PTA. I have already mentioned in PTA, pure tone audiometry or audiometry, it shows conductive hearing loss about 20 to 40 decibels unless there is ossicular discontinuity, because in that case there will be greater than 40 decibel of hearing loss, right? And another investigation, right, the first one investigation we already talked, PTA, right? PTA. And talking about another investigation is tympanometry. And talking about tympanometry, what will happen is that it will show type B curve, right, from B Bogne, right, Bogno, that means flowing, right? So B Bogne, otitis media with effusion, there is fluid, so Bogne, so it shows B pattern of curve, right? Okay, and talking about another investigation we can do is X-ray, right? X-ray, we can do X-ray of mastoid, and in X-ray of mastoid there will be clouding of ear cells. Similarly, we can do X-ray, right? We can do X-ray of what? Soft tissue nasopharynx, right? Soft tissue nasopharynx. In soft tissue nasopharynx, in lateral view, what we see is, in lateral view we can see hypertrophy of adenoid, right? Hypertrophy of adenoid. So these are the investigation. In investigation we talked about what? We talked about our pure tone audiometry, how we are going to do it in different age group. We talked about tympanometry, right? Tympanometry, the type of curve, right? B curve is seen. Similarly, we talked about X-ray, right? Lateral soft tissue of what? Nasopharynx. We talked about the X-ray of mastoid cells also. Now talking about the treatment procedures, right? Treatment procedures, it is also interesting. Talking about the treatment, right? Now initially what we do is we need to see if there is, right, upper respiratory tract infection at the present time or not, right? We need to see there is upper respiratory tract infection or not, right? Upper respiratory tract infection is present or not, or we can say there is edema in eustachian tube or not. Now if yes, right, if there is presence of URTI or edema in eustachian tube, then what we can do is we can go toward medical treatment for 1 week, right? Now And another thing that we can do is we can do general measures, right? General measures for middle ear aeration, right? If there is presence of what URTI and edema of in eustachian tube, then, and if there is no such condition, right, then what we'll do is we'll do general measures only. General measures for middle ear aeration. That's what we were doing here. So we are clear. Now if there is presence of edema or URTI, then what we do go for medical treatment for about 1 week, and in both the cases, if there is presence or absence of this URTI or edema, then what we are going to do is we are going to do general measures in both the cases. So what are the medical treatment? Now talking about the medical treatment, right, in medical treatment what we can do is, okay, let's go to our medical treatment. In medical treatment what we can do is we can, okay, let's focus right here initially. In medical treatment what we can do is we can give topical or systemic decongestant, right, we can give what, topical or systemic decongestant, right, and along with this we can give antihistaminic also. Now we are giving topical or systemic decongestant along with antihistaminic, and this is for what? This is for our eustachian tube edema. We have already mentioned if edema is present, then we are going to give medical treatment, right, and that's medical treatment is, the medical treatment is what? It is topical or systemic decongestant along with antihistaminic, right. Now we did it for what? Eustachian tube edema. And what about URTI? And for URTI what we are going to do is we are going to give what? We are going to give the composition of amoxicillin, right, amoxicillin plus clavulanic acid, and it goes by name of amoxiclav. So that is what we are going to do in the case of what? In the case of for what? For URTI. So we treated both. We treated URTI also, we treated what? Eustachian tube edema also, right. Now these were the medical management, right. We are giving what? We are giving decongestant, right, nasal decongestant such as xylometazoline, right, xylometazoline, oxymetazoline, and anti-allergic, antihistaminic, right, we can give. And okay, we are giving these two for what? We are giving these two for our eustachian tube edema. And what about our URTI? For URTI, right, we are giving what? Antibiotic that goes by the name of amoxiclav, which includes what? Amoxicillin and clavulanic acid. And now for middle ear general measures or for middle ear aeration, what we are going to do is we are going to do general measures, right. Now what are these general measures? These are non-medical treatment, right. Now talking about these general measures, frequently we perform what? Frequently we perform Valsalva maneuver, right. Valsalva maneuver, what we do is we offer chewing gum, right, chewing gums. And another thing we can do is we can do eustachian catheterization, right, catheterization. So what we can do is we can do Valsalva maneuver, chewing gum, we can offer chewing gum to patient, we can do eustachian catheterization. Now with these measures, right, with these measures what we'll do is observe the patient on monthly follow-up for 3 months. Now in maximum of the cases there will be what? OME will be resolved within 3 months, right. So what we are doing, we gave what? Valsalva maneuver, Chonibi maneuver also we can give, right, and then along with it we can offer chewing gum, we can do eustachian catheterization, right. Now if these maneuver fails, then mechanical device such as auto-vent tympanic membrane balloon or ear proper tympanic membrane can be used, right. This can be used. Now as I'm already saying, what we are doing is we were giving medical treatment and we are giving general measures, right. Now after that measures, we'll just ask patient to follow up within 3 months, right. After 3 months, now within 3 months maximum of the otitis media with effusion cases are resolved, right. Now if it persists for more than 3 months, then what we are going to do? Now if there will be, right, otitis media with effusion for more than 3 months, then we have one criteria. Now according to that criteria we are going to do myringotomy, right, myringotomy. Now what are the criteria? And talking about criteria, right? Okay. Now talking about criterias, right? If I've already said, if effusion persists for more than 3 months, right? And 3 months, right, in the if it persists for more than 3 months in what, bilateral case, and in unilateral case, right, if it persists for more than 6 months. That is one criteria. And another criteria is if there is significant hearing loss of greater than 25 decibel, right, and if there is speech and language delay. And another is if there is complication like otitic meningitis, right, or impeding cholesteatoma formation, right, impeding cholesteatoma formation. So what are these? These are the criteria. One is if there is infection for more than otitis media with effusion for more than 3 months in the case of bilateral, and in the case of unilateral if 6 months, and if there is what, greater than 25 decibel of what, hearing loss, and if there is what, speech and language delay, and if there is otitis media otitis meningitis or cholesteatoma formation. And in this case, right, and if these criteria are met, right, if this criteria met, then what we do is we do myringotomy, right. Now myringotomy, right, and where it is done at antero-inferior quadrant, right, and it is done with what, it is done with radial incision, right, it is done with radial incision. Now why we are doing this myringotomy? We are doing it, we are doing incision, right, we are doing incision so that we aspirate medullary fluid, right. We are now going to aspirate medullary fluid now, and after aspirating medullary fluid, what we are going to do is we are going to insert chromate for continuous aspiration, right, continuous aspiration. So this is how we are going to what, manage the case of otitis media with effusion. So we are clear about what treatment modalities also, right, treatment modality also. In treatment modality, we are going to see if there is what, eustachian tube edema or upper respiratory tract infection or not. If as, right, if no, only general measures can be done, right, general measures can be done. If X, then what we are going to do is medical treatment along with general measures. Now medical treatment we already talked about. For eustachian tube edema, we are going to provide decongestant, along with them we are what, we are going to provide antihistaminic, and for what, for our UTI we are going to provide antibiotic. And the patient, right, and general measures, what we are going to do, we are going to provide we are going to ask patient to do Valsalva maneuver, we are going to ask patient to have chewing gum, or we can help with eustachian catheterization also. And within 3 months it will be resolved, and if it will not be resolved, then we will need to go for myringotomy, and we talked about various criteria for myringotomy, right. And myringotomy we are going to do it anterior inferior quadrant with radial incision. So this was about what, this was about the management of what, management of otitis media with effusion. Yes, myringotomy we are going to do it for aspiration of fluid, right. Chromate insertions will be done, and it is device used to provide continuous aeration of middle ear, right. Tympanotomy or cortical mastectomy also can be done, but it is not done, right, so much, right. And surgical treatment of causative factor can be done. So as you can see, what is this? This is the Valsalva maneuver. And what is this? This is our otoscope and otoscope finding. We talked about that thing, right. And Valsalva maneuver, how you are going to do, look, take a deep breath and pinch your nostril closed with your fingers, right. And we are going to close mouth also. Now blow air out of your nose to regulate the air pressure, right. This will help in what, providing patency to our eustachian tube. What is this? This is chromate incision insertion. As you can see where it is done, it is on an anterior inferior quadrant only, right. So these are what, these are our what, these are our various Valsalva maneuver, chewing gum, right. Warm compressor also can be done, like you can see 20B maneuver is also mentioned here. So these are what, these are the management, right, management, clinical features, signs, symptoms, history of otitis media with effusion. And if there will be question about sequelae, and there is asked question about sequelae of otitis media with effusion. So the sequelae can be initially tympanic membrane, it will be atrophied, right, there will be atrophy of tympanic membrane, and atelectasis, right? Atrophy and atelectasis. There will be what? Adhesive otitis media. Similarly, after adhesion, what we can see is tympanosclerosis, right? Tympanosclerosis. Now after tympanosclerosis, we can see cholesterol granuloma can be seen, right? Cholesterol granuloma can be seen. And then what we can see is retraction pocket of cholesteatoma, right? And these are the sequelae. So tympanic membrane will be atrophic, right? There will be atelectasis. There will be adhesion of otitis media. There will be of tympanosclerosis after adhesion. There will be our cholesterol granuloma formation. Retraction pocket will be formed there. So these are the sequelae of otitis media, right, with effusion. So this is how we are going to handle the case of otitis media with effusion.